Today we're going to talk about the Sentara Pediatric Early Warning Score. So a quick overview of SPEWS, or the Sentara Pediatric Early Warning Score for providers. So Sentara PEWS is a pilot that we're doing here at Rockingham. It's a mixture of the Children's Hospital Early Warning Score and a modified Brighton PEWS. So the CHOOSE is the most validated tool that we could find in the literature, both in sensitivity and specificity. And the modified Brighton put it into the ABCD approach that we use from PALS. We are piloting it here at RMH inpatient, and then it will go to the other inpatients, and then ultimately to the EDs across the system. So the goal of this project is to prevent cardiopulmonary arrest, unplanned transfers to PICUs by intervening early. Your SPEWS score will actually show up in a pediatric vital sign screen. So we're used to using the adult vital sign screen, but we'll start using the pediatric vital sign screen. And that's what I've got shown here. So you'll do vital signs and then the SPEWS score and then pain. It's really important that we document at the time of vital sign documentation. So when you go in and assess your child and you're doing vital signs, you need to do the SPEWS score at that time. UVA has done research on why are they still having unexplained, unplanned transfers to PICUs and cardiopulmonary arrest, and what they came down to was that nurses weren't charting at the time, and if they went back and back charted, they would have realized that the patients were at risk of deterioration. So this really isn't going to work unless we actually do it at the time of vital sign. So because we've mixed this with the Brighton PEWS, we have the ABCD. We have it in the order that we use with PALS. So A is airway. Basically, can they maintain their airway? B is breathing. What's their rate? Are they having effort? Are they having apnea or retractions? Notice with breathing that in some cases you need increased rate as well as increased effort. So for a 1, you would need an increased respiratory rate with effort. With 2, if you just have an increased respiratory rate, you would also need effort. And basically what we're trying to do is prevent falsely scoring people just because they've been running around or they're scared or they're crying or they're having a fever. C is circulation. So again, we are taking into account fever, activity, pain, and with those increased heart rates. So otherwise, circulation is color, it's cap refill, as well as heart rate and ectopy. D is disability. Are they alert? Are they at baseline? So in addition to your ABCD, we basically have scores of 0, 1, 2, and 3. So the easiest way to think of this is 0s are not sick, 1s are sick, 2s are sicker, and 3s are sickest. And the sickest, anything on a 3, should be an immediate intervention. 3s need to be taken care of immediately or they will die. So 0s for airway, maintaining airway on their own. There's no excessive secretions. 0 for breathing, on room air or on their home oxygen level. They have a normal respiratory rate. They're not retracting. They're not nasal flaring. 0s for circulation. They have normal color, good cap refill, normal heart rate, no ectopy. 0s for disability. They're playing and sleeping appropriately. They're at their baseline. 1s, we start getting a little sicker. So 1 for airway. They've got a little bit of stridor if they're moving around. They've got, just some loose, mild wheezing. They have mild secretions that they can manage pretty much on their own. They only need interventions of nebs or suctioning every 2 to 4 hours. They're not needing a whole lot of PRNs. 1 for breathing. They're needing nasal cannula oxygen. If they have intermittent apnea, they can resolve. They don't need to be stimulated or anything. They've got a little bit of increased respiratory rate along with a little bit of increased effort. So nasal flaring or just really mild retractions in only one location. A 1 for circulation. They're a little bit pale or mottled peripherally, or they've got a little bit slower cap refill, a little bit of tachycardia that you really can't account to with fever, activity, or pain. Or they're in a little bit of irregularity or ectopy that's been kind of existing for them. And then 1 for disability. They're a little sleepy when they're awake. They're kind of out of it when you're not disturbing them. They just don't feel good. 2s are definitely sicker. These are the kids that you really need to watch closely. And these are the ones where you may need to be notifying providers based on your escalation algorithms. So 2, you need to prop them up, or you're moving them around trying to get their SATs back up. They have stridor at rest, they're grunting, or they're really wheezing. They're needing interventions, nubs, and suctioning every 1 to 2 hours. You're giving PRNs as often as you can give them. 2s for breathing. You're needing up to 50% oxygen to maintain those SATs. So you're needing more than just a couple liters of nasal cannula. They may be on high flow up to less than 50% or on a mask. They're needing repositioning or stimulation with apnea. They've got a increased respiratory rate even higher, and moderate retractions. So retractions in more than one location, or more moderate retractions. 2s for circulation. They're gray, pale, mottled centrally. They've got a really slow cap refill. Their heart rate's even more elevated, and you can't really account to it for fever activity or pain. 2s for disability. They're irritable, they're difficult to console, or an increase to regular baseline seizures. And then the 3s, you really should MERT. 3s are really sick. If you need to insert an oral pharyngeal airway or a nasal pharyngeal airway, or you're bagging them, that's a 3. Or if you're needing to do nebs or suctioning more often than hourly, so every 30 minutes to an hour, then that's a 3. 3s for breathing, they're needing over 50%, and that's transfer criteria really on high flow to maintain a SAT. So you've got them on a non-rebreather. The respiratory rate's up to 30 breaths per minute, above normal for age, or 5 breaths a minute less than normal. So when you've got a patient with high respiratory rate and then they start slowing down, but they're still retracting and all of that, then you should be really concerned that child could go into cardiopulmonary arrest. Or they have apnea requiring interventions other than repositioning or stimulation. Circulation 3s, they're gray or cyanotic, really slow cap refill, heart rate 30 above normal. They've got some weird funky rhythm going on, so this would be your SVT or VTAC with a pulse or anything like that. Bradycardia, that is a sign of impending doom with a kid that has been sick. New or increased ectopy, irregular heart rate, or heart block. So the bradycardia is especially worrisome if they have been tachycardic and sick. Some kids do have heart rates that are lower than normal, but definitely if they've been tachycardic previously and then go bradycardic, or they're bradycardic in association with low saturations. 3 in disability, severe neurological compromise, lethargic, they're confused, they're floppy, they're not responding to pain. Those are the kids that you're sticking, and they aren't crying, or they're having more frequent prolonged seizures or pupil changes. So nursing can add a point or 2 for staff and family concern. So staff concern if they're really worried or their gut is that something's wrong but they can't get a score high enough to escalate, or family concern if the family is concerned, or if there's no family for an extended period of time, which puts the patient at higher risk of not recognizing issues. So your PEW score options are low, so your patients will be either scored as a low. Low patients get routine care, vital signs and PEW score or SPEED score every 4 hours, unless they have gone from a 0 to 2, in which case we'll ask them to notify you. A moderate is a score of 3 or above. They're supposed to notify the provider of an initial score of 3 or above, and then any increase in that score after that assessment. That they should request that the patient be put on a continuous pulse oximeter and tele. This is part of the recommendation from the latest study from UVA. They have the charge nurse assess the patient, and then they do a Q2 hour reassessment, vitals, and SPEED score while the patient maintains a moderate or high. For a patient that scores an 8 plus, we're asking that providers see them urgently, that the nurse considers calling it as a MERT, or how we do it here as a pediatric code, that would be a MERT, but that they also notify you if they have any individual score of 3. So you see around here all the individual scores of 3. Those would definitely be worrisome. So things that you may get called for, regardless of level, we're asking that they notify providers if there's an increase in the total score by 2 points from a previous score, if they have a new score of 2 in any category that they can't resolve with current orders. So breathing treatments that are already ordered, Tylenol, Motrin, things like that, haven't resolved those individual scores of 2. And then any score in the moderate range that's new, or any increase of a moderate score. And then we're asking that you see urgently, emergently, any patient that has a score of high, so an 8 or above, or any new or recurring individual score of 3. You can add SPEW score to your patient list as well as a change from previous shift.
So let's walk this out through a shift. So I have here a 1-year-old, ignore the sidebar, a 1-year-old here with croup, and we're just going to kind of go through my day's progression. So she was admitted last night and had gotten some epinebs in the ED, and so they admitted her about 3. Everything was looking good. She slept pretty well, didn't need any PRN nebs. This morning when I got here, she was running around the room. I got a set of vitals and listened to her, and this is where we're at. So we have a low-grade fever. That's not unusual. Pulse is 145. Respiratory rate is 36. So I'm going to use my vital sign card and look at that. So this would be an infant. My heart rate can be up to 180. My respiratory rate up to 53. So we're good there. Blood pressure is good. Stat's good. I just have the high humidity blow-by going. She's on room air. So I'm going to go ahead and score her pews. So she's going to get a 1 just because she is running like crazy and still has some stridor with that activity. So she has stridor with activity, but otherwise good. She hasn't had a neb in about 5 hours now. So that's looking good. So she gets a 1 here. For breathing, she gets a 0. She's on room air. She's got a normal respiratory rate for age, and I don't see any retractions or nasal flaring. Circulation, she gets a 0. She is pink. Her cap refill is brisk. Her heart rate is normal. And I don't actually have her on the monitor, so I'm going to assume no activity. Disability, she is playing, sleeping. She's playing appropriately and to her baseline. We're good there. I'm not concerned. Family's not concerned. That's going to give her a SPEW score of 1. So for 1, I'm going to do routine cure and reassess every 4 hours. So I peeked my head in at noon, and she was sleeping. She was 94, 95 on the monitor on our continuous pulse ox. So I left her alone, and then she started dipping. So I went in, got a full set of vitals, checked the probe. Her temperature is still low grade. Our heart rate's up a little bit, but we're still okay based on our numbers. Her respiratory rate, we're not okay, so my max respiratory rate for her age would be 53. So I'm above that. Blood pressure is still holding. Stat is not holding. So I'm going to go ahead, if you see I've written a note that I placed her on high humidity blow-by, and croup is really the only time that you would do that in an inpatient world. All right, so I put on some blow-by. I'm going to do an initial evaluation. I'm also going to go ahead and give her an epi-neb, and I'm going to go ahead and score her now, even though in practice I wouldn't. I just want you to see where those numbers change. So let me move this out of the way. So she's going to get a 2 for airway because she was resting and she still had stridor at rest. So stridor at rest is going to give me a 2. Her breathing rate is elevated. So she's going to get a 1 because she has a respiratory rate up to 10 breaths per minute above her normal range, And in addition to that, she's got some mild subcostal retraction. Circulation's still good. Her heart rate's all right. She's still pink, good pulses. So I'm good there. She is not what mom thinks she should be post-nap. So generally post-nap, she wakes right up and she's really alert, and she's really not. So she is going to get a 1 for mild neurological compromise. She's sleepy. Mom isn't, it's hard to tease that out with toddlers. Did they just not get enough sleep last night? What's going on? But I'm going to give her a 1 for that. I'm not horribly concerned because it's been a long time since the treatment, so I'm going to see how that goes. Family's not really concerned. They're like, here we go again. So that's going to give her a score of 4. So my score of 4 says that I should notify the provider and then reassess her every 2 hours. Consider putting her on a continuous telemetry monitoring. She's already on the continuous pulse ox. If I'm not the charge nurse, I'm going to have the charge nurse take a look at her. So I'm just going to let the doctor know that she did hit that number. Just kind of an FYI, I'm going to go ahead and give her EpiNeb. So 15 minutes post EpiNeb. This would honestly, I would just text Paige. I'm not hugely worried about this patient right here, right now, but this patient is still sick. So 15 minutes post Neb, here we are. I'm still running low-grade fever. My heart rate's up, but I'm not hugely worried about that because of the EpiNeb. So we've given her an EpiNeb, and she's kind of jittery, and so I'm kind of expecting that heart rate. Her respiratory rate's better. Still not as good as it was, but it's better. So my respiratory rate parameters are up to 53, and my heart rate parameters are up to 180. So I'm really okay on both of those. She's also kind of waking up and fussing and, being a toddler woken up too early from her nap. So her stat's good. I was able to discontinue the blow-by once I gave her EpiNeb. And she's just back on the high humidity blow-by in the room. So here's where she's scoring now. She's scoring a 2 because she's still mostly at rest and still got some stridor, although that's getting better. But we're just going to kind of keep an eye on her here. She's getting a 0 for breathing because she's back on room air and she's no longer retracting. She's breathing easier. Circulation remains a 0. Disability is back down to a 0 because she's woken up and she's watching her show and eating her animal crackers. So that's all good now. Staff's not concerned. Mom's not concerned. So that brings her back down to a 2. All right, let's do another one. I have this teenager who was post-appendectomy. So I started out my shift with him. So his vital signs were good. A little bit of a low-grade temperature. I have him doing his IF. Pulse was up a little bit, although it's just barely outside of my normal. So my normal for adolescent gets me to 100, and he's at 105. But honestly, I'm going to attribute that to his pain. So when I scroll down here in a minute, you'll see that his pain level is an 8. So I'm really going to think that that has more to do with pain than it does a cardiac issue. Respiratory rate's 20, blood pressure's good, stat was good, he's on room air. In terms of his P's then, airway, he's maintaining his airway on his own, no excessive secretions. Breathing, stats are good, normal respiratory rate for age, he's not retracting or nasal flaring. Circulation is good, he's a normal color, good cap refill. Disability, he's alert and oriented, playing on his phone. I'm not concerned, family's not concerned, his SPEW score is 0. So I'm going to continue routine care, and I'm going to reassess him every 4 hours. So about noon, I was heading in to see him anyway, and he says, I just feel strange. So he's not on a pulse ox or anything, he's just a routine post-op. I was just waiting on the surgeon to see him. Like, my heart just feels weird. So I put him back on the monitor. He's still running a bit of a low-grade temp, and his heart rate is 188. So I put him on the monitor, and I see SVT. So obviously I'm not going to stop and do his SPEW score right then. I was going to actually intervene and I'm going to call a MERT. But I'm going to show you how all that connects here in a minute. I just don't want you to think, no, you've got to do all of the right things before you can call a MERT. Absolutely. Somebody's an SPT, call a MERT. Respiratory rate's up a little bit. He's kind of anxious. Blood pressure's up a little bit. He's kind of anxious. That's still good. He's definitely still stable in this rhythm, which means I will probably start conservatively based on my PALS algorithm. So here are the vital signs score. So you see his normal heart rate should be up to 100. His normal respiratory rate should be 20. All right. So if I were to have scored him right then, right there, he would get a 0 for airway. His respiratory rate's up a tidge. You could give him a 1 for that, although I really think he's just anxious. He gets a 3 for circulation. So anytime you get a 3 on anything, you need to notify the provider and consider a MERT. So you'll see that here when we get down to the scoring. So a 3 heart rate is greater than 30 beats per minute above normal for age. I can't consider any fever activity or pain that would have caused that. And he has a new irregular heart rhythm. So if he's an SVT, that definitely counts as a 3. He's still awake and alert. That makes a difference. Unstable gets a cable. So if he had other signs of cardiopulmonary compromise or was less reactive, then we would actually synchronize cardiovert him. That's funny. Yes, I'm concerned. And yes, family's concerned. So he's going to get points for that. But that's still only going to bring him to a moderate because his only issue is cardiac. I didn't actually ask him his pain right then and there. We just got him some adenosine. So after a couple doses of adenosine, after I called a MERT and we put him on the monitor and we provided him with the medication, when I got his next set of vitals that I've recorded here, not just on the MERT sheet, he has broken out of his SVT. So his temperature is fine, pulse rate is fine, his respiratory rate's back normal, his blood pressure is good, his SAT's good, and he resumes back to a 0. So again, this we've looked at the MERT algorithm, so obviously SVT or something like that would be an automatic MERT, but also you can see how it's reflected here in the PEW score as well. All right, and here is our final case study. I have here a 3-year-old who is just being admitted with asthma. This kid is coming up to us. They've been on Blood-By in the ED, so they came up about 8. So when I got this patient, they were febrile. Their heart rate is high. Their respiratory rate is high. Their SAT is 80. They'd forgotten to bring oxygen with the patient. So let's look at those vital signs. So we're looking at this patient's 2 to 3, so somewhere between the toddler and preschooler. My highest heart rate should be about 140. Highest respiratory rate, 37. If they're closer to 2, 20, 28 if they're closer to 3. So regardless, this kid is sick. All right, so I'm obviously going to put them on some oxygen. So I started with 3 liters just to see what that would do. So when I listened to this child, they were really diminished, really wheezy. So what I could hear was pretty much wheezing. So they got a 2. They also got a 2 for breathing. Their respiratory rate is up to 20 breaths per minute. They've got moderate retractions. They've got subcostal and supraclavicular retractions. So they're getting a 2. At this point, I don't have them on more than 50% oxygen, although I'm going to see how they do on this. The respiratory rate is not 30 breaths per minute above normal, but I'm going to watch them carefully and hope that they improve. Heart rate is up, so they're going to get a 1 for heart rate 10 to 20 over the normal. So the normal is somewhere in that 120, 140 range, and they're at 160. I'm going to give them at least a 1 there. Even though they've got a fever, that still seems higher than I would expect for that fever. Disability, they're still pretty alert, crying, playing. I'm kind of concerned, but not enough to say, I think their score should be higher. Mom's not really concerned yet, so that would give them a 5. So a 5 is going to say that I need to contact the provider, make sure they're on telemetry and on continuous pulse ox, and I'm going to continue to intervene. So in terms of the sick or sickest, we're definitely in the sicker range. And I'm hoping that some interventions are going to turn them around. So I've put them first on the 3 liters, and then I started on a non-rebreather. I've given them albuterol, and actually I'm starting on my second one, and then this is where I'm at. So the non-rebreather has not helped the heart rate or the respiratory rate, nor has albuterol. Blood pressure is still holding. SAT is only 88% on a non-rebreather. So in PAL's world, if you have a SAT of less than 90 on a non-rebreather, you're going to need to start bagging. Because if you can't maintain on 100% oxygen, then there's nothing else we can do except bag you. So this could give this kid a severe airway. I'm going to need to bag to maintain that airway. They also get a 3 for severe breathing compromise. They're needing oxygen over 50%. So that's going to go there. Mild circulatory compromise, again, still that heart rate's up. I don't have any issues on the monitor. Still pink, still good pulses. So that just gives me a 1 on circulatory. This kid is no longer really responsive. So they are lethargic, just kind of floppy. So they're going to get a 3 here. Oops, I keep doing this. Staff is concerned. Yes, staff is concerned. Family, I'm going to guess, is concerned, but I've already got a high enough score here. I'm already at 11. And regardless of what number I have here, I have a 3 in any category. So 3 in any category should indicate a provider seeing them urgently and a pediatric MERT, which we would call as a pediatric code. So I have a 3. Obviously, I have a child who is struggling. I'm going to be starting to breathe for the child using an ambu bag, and this would definitely be a MERT situation. And then finally, I just want to show what this patient list looks like for a variety of these patients. The first patient was the Kruper. The Kruper started out good, got worse, got better. So my SPEE's change is actually -2 because by the end of it, it had gone from a 0 to a 2 to back to a 0. The same with my SPT kid. They had gone from a 0 to a 5 to a 0. So that also gave me a change of -5. My final child, which is this one with the asthma, went from a 5 to 11, which gave me a +6. So this is how you read the SPEE's change column. And the first one was just somebody I was playing with that wasn't actually part of a case scenario. So here you see all the different colors. 0, 1, and 2 will show up green. Moderates will show up yellow, and a high will show up red.